Hello, I'm Joey Branton, Senior Vice President of Strategic Initiatives at Pulsara. I want to thank Beckers for inviting me today to talk about telehealth and virtual care events, as well as about leveraging broadband access and the internet on behalf of patients and providers. First of all, a few little disclosures about myself. I'm a 30-year recovering paramedic, having been a frontline firefighter and paramedic for many years, as well as serving in administrative roles in both EMS and emergency medicine. Add to that, I'm also a recovering 20-year healthcare IT professional, having been involved through EMS and emergency medicine as well as emergency management through the transformations of HIPAA, electronic medical records in both those areas. And then lastly, sort of overlapping those two careers, I'm also a 17-year recovering emergency management professional. If you live on the Gulf Coast of Louisiana and you're in healthcare, you're going to be in emergency management whether you like it or not. So starting with Hurricane Katrina in 2005 and every subsequent hurricane since, I have worked and supported both local, state, and regional response to devastating effects of the kinds of storms we have on the Gulf Coast that affect both patients as well as their healthcare institutions. So what does this have to do with telehealth and virtual care events or leveraging broadband access and the internet on behalf of patients and providers? Well, let's go back to the beginning of the global pandemic. Sometime around late February, early March 2020, as the world faced a global shutdown with social distancing, masks, and the surge of COVID patients that were overwhelming our hospital and healthcare facility resources, the world was changing under our feet. So in the face of this new threat and the new way of how we had to manage patients and even our own healthcare institutions, it was obvious that common mobile technology we use in our personal lives every day, like making a video call with families, was not only an option for delivering distributed healthcare, but maybe the only option in many cases to prevent potential exposure of not just providers, but of patients to providers. We suddenly realized that our fixed locations of medicine, essentially dragging patients to healthcare, was our established way of doing medicine in communities across the country. And in fact, it could not flex to meet the patient where they need care and when they need care. Well, I gave it a lot of thought as a recovering clinician, technologist, and emergency manager, and it was pretty clear to me. I've always known that healthcare has been artificially siloed into pre-hospital EMS care, acute care hospitals with a range of acute inpatient services, affiliated healthcare facilities like nursing homes, long-term acute care hospitals, skilled nursing facilities, and just a multiple varieties of urgent care delivery systems. While some progress has been made on interoperability of data systems, communication between siloed organizations in our healthcare continues to rely on legacy communication systems. Radios from EMS, phone, fax, pagers, all the things that have been used for decades in our communications platforms. The legacy systems, such as data systems, electronic patient care records in EMS, electronic health records in hospital space, and even the healthcare information exchanges, connected data between providers. But, as we well know, they often don't share common data or data sharing interfaces without a considerable cost for each facility many times. I can give you a good example of that, a real life example. So quite early in the pandemic, we got involved in some state coordinating centers across the country. We got involved with some transfer centers across the country, and it had been a while since I'd been in any of those, and particularly with the kind of surge we were seeing that was not just localized, but was also across the country. And I was, surprised but not completely stunned that you got a room full of people with phones ringing off the hook. You can't hear yourself think. People are yelling over each other to figure out who took the last phone call, and they're all trying to do this over a single patient event many times. And that was true in transfer centers that I went to or state coordinating centers that I went to. And so what I realized is that the traditional methods that we had for solving these problems completely broke down. So under the surge of the pandemic, not only did the normal referral patterns break down and local resources get overwhelmed, but we really didn't have a way to solve where's a bed for a patient. We convinced ourselves for years, well, if we know the hospital resource data, then everything's going to be okay. We know where there's a bed, we can match a bed to a patient need, and everything will be fine. None of that worked during the pandemic because the bed situation changed so fast and so dynamically, and the needs of patients that needed to be served in an outlying facility were so nuanced. Not only did they have COVID, but they had diabetes and they needed dialysis. And so all of these complexities broke the system down, which is why you saw people languishing across the country in these rolling surges of COVID, not able to find the right place for the patient with the right services. Sending facilities were making dozens of phone calls to find beds for each patient. Phones are ringing off the hook at the receiving centers, much as they are at the state coordinating centers and the transfer centers. You can't stop the phones ringing when you don't even have a bed. But it's not all bad, because before the pandemic hit us, there were already some forces in play, particularly in the EMS space, that came to the forefront. So I think about the CMS ET3 initiative, Treat in Place, Transport to Alternative Destinations. I also think about the mature community paramedicine programs in the country, as well as the mature mobile integrated healthcare systems in the country. Brick and mortar healthcare facilities began figuring out, how can we facilitate distributed care to our patients in their own homes and communities in both the urban and remote rural environments? Everybody's thinking about it now. How do we not drag patients to care? Another significant factor that came into play, and we talk about disparity in this country along many lines, but we have to accept and understand that there is a disparity in healthcare in this country. It's related to many, many factors, but one factor, quite honestly, that's going to get solved is that how do you actually effectively deliver that care across a broad spectrum of urban and rural communities? You know, broadband access, or the lack of it, has actually only highlighted the difficulties of providing distributed care in the pandemic. So now, and rightfully so, I would add, we see billions of federal dollars being allocated to the states to actually solve the broadband connectivity issue as far out into the communities as they possibly can go in every state. Closing, hopefully, the disparity gap between those who have connectivity and those who don't, which in fact means those who need access to care anywhere there may be and where it can be delivered. So I think it begs the question at this point, what is the next evolution that includes broadband access, mobile technology, moving care to the patient at the right time and the right place? Well, I believe it's a fundamental shift in thinking to see our world where we use the internet to navigate building a system of care that scales as needed on demand to meet any community's need and provide a safety net of care for any patient with any presentation anywhere. By leveraging the internet on behalf of patients and providers, we can create a true system of care that scales the delivery of healthcare on demand anywhere and at any time. You know, I know a lot of what people are probably thinking is, well, you know what, this has been solved to a large degree because, you know, modern connected hospital outreach programs have access to telemedicine visits with primary care and even specialty physicians. And I would agree that much has been accomplished for patients with established patient-provider relationships or a relationship with a hospital. But there's another place where healthcare disparity exists. What about everybody else? Yeah, and there's a lot of everybody else in the world that does not fit into those categories. What about the patients who are in transitions of care? Patients who fall out of their care plans unexpectedly. Unscheduled, undifferentiated patient events, time-sensitive emergencies, underserved populations. And of course, how do you truly connect distributed teams across multiple organizations around those types of dynamically evolving patient events? So I do believe that EMS, hospitals, and healthcare systems are going to have to figure out how to embrace mobile technology for real-time communication and logistics. The legacy systems continue and for some time will be continuing to be limited to their silos, as they are unable to leverage communication across organizations and distributed teams. What do? They always revert back to phone, fax, and pagers, multiple phone calls. And I don't believe, quite honestly, post-pandemic, that our patients and our communities are okay with healthcare systems not having the same effective communications and logistics that we see in other industries. Simply because we're unwilling to adopt in our professional experience the same technology we embrace in our personal lives. I know that there's an elephant in the room, Because as I talk about mobile technology and I talk about the internet and I talk about broadband and I talk about, dragging care to patients instead of dragging patients to care, this is always going to be there. And it's this thing called privacy and security. It is the elephant in the room. So I would say, in my experience over the last 2 decades, the reluctance to innovate around mobile technology has primarily been driven by healthcare, well-meaning healthcare IT professionals around their concerns about privacy and security. I've, like I said, spent 20 years in the IT industry, so I'm perfectly familiar with the cybersecurity threat out there, and I understand it personally and I understand it professionally, and I can tell you that there are no absolutes in that. It's an arms race. It's the good guys against the bad guys. The bad guys many times are more well-financed than we are, but nevertheless, we have a responsibility to stay in the fight. There are no absolutes, but I can tell you this. Other people, other companies such as Amazon, Google, and Microsoft, they are successfully solving this problem at scale, and at a scale of spend that not a single one of our large healthcare systems, or maybe even the government, can do, because they're motivated to do it because it's profitable to them. So they invest significantly more capital in solving our privacy and security problem than any one of us can do alone or collectively. I'd just like to reiterate, our patients really don't understand why our healthcare systems are not as agile, responsive, secure, and as effective as ordering something off the internet. The need for network communication and logistics has been further demonstrated by the worldwide pandemic of the last 2 years. So here we are. If hospitals and affiliated healthcare facilities are going to serve their patients in this new age, we're going to have to figure out how to overlay our current technology stacks and our current spend with mobile-first technology that extends our reach at scale and reduced cost to all patient populations and all locations. For EMS, if you're seeking ways to integrate into their communities, deliver care in the best place for the patient, reduce costs, involve other providers whenever and wherever they may be at the time of need, then we likewise have to figure out how to navigate the internet on behalf of our patients and providers using mobile-first technology. In the emergency management space, when we have these surge events ranging from natural to man-made disasters, hospitals are trying to find care for their patients. They need a simple way to inform state and other resources of their needs and engage statewide receiving centers. If you have the resources to receive patients, you need a way to locate them. And if you're at capacity, you need to stop the phones from ringing. There is a burning need to provide pre-hospital, hospital, and other affiliated healthcare facilities access to state or other resources in a standardized way when we're under surge. So here's my premise. I think it's reasonable for all our healthcare systems to evolve toward an adoption of modern, mobile, and browser-based SaaS solutions to increase system efficiency, effectiveness, collaborative communication, and predictable budgeting. Also, it provides the agility to scale from daily healthcare needs of any local area into a regional, state, or national response for surge events. Importantly, adoption of secure SaaS, mobile, and browser-based communication and logistics solutions can provide exactly what is needed for this problem. How do you create team communications across organizations at a sustainable and predictable cost, thereby allowing all emergency management systems, pre-hospital providers, healthcare facilities, affiliated healthcare facilities to use the same system that they use daily to scale quickly for local, regional, and national emergencies. So back to the broadband topic, which is part of what the topic of this conversation was about at the beginning, is good news. Your broadband access is as bad as it's ever going to be in the United States. As I said, billions of dollars are being allocated to the states to solve this problem. So it's as bad as it's ever going to be. we, as stewards of our own taxpayer dollars in the healthcare industry, have to figure out what that access and broadband connectivity means for the future. I think it means we have to innovate rapidly. We have to remove perceived barriers around privacy and security, and we have to serve our citizens and patients. As I shared with you in the introduction about my past and my past experience, and certainly you can look at me and tell that I've been in the industry for some time, going now on 40 years. One of the things I try to never forget to mention when I'm talking to somebody is that I'm actually doing penance at this stage of my life for some of the other things that I've done over the last decades in healthcare. I, along with many, many others in this country, thousands, if not tens of thousands of people in the healthcare industry, have connected data and databases through EHRs and HIEs, and we convinced ourselves, hey, we're solving the problem. You know, it's great. We're going to have all this connected data, and it's going to create a better experience for patients, and it's going to a better experience for providers, although I don't know a provider that really likes their electronic medical record. And we're going to have better quality, and of course we're going to reduce cost, which means that the federal government will pay us and the private payers will pay us appropriately so that we can actually be there for the patients. As I was reminded one time very distinctly that if there is no money, there's no mission. So yeah, we all drank the Kool-Aid, including myself. And so there was a part of it throughout my career that I thought, well, but there's still something missing. We're still missing something. In fact, I truly believe that in many times we exacerbated the problem because we forgot the most important thing about our job in healthcare. That is, at the time we deliver the healthcare to the patient, in the present of the patient's situation. It is first and foremost, at a patient's time of need, really about the patient, about their families, and the providers, by the way, who are taking care of them in real time. So connecting the data was not enough. We have to connect the providers. And quite honestly, we have all the modern tools now to make that easily done, easily accomplished, and affordable. Along the lines of HIPAA and privacy and security, I've got a little anecdote. I've repeated this experience every time I've sat in a meeting and talked to my peers as a recovering technologist, my peers in the IT, information governance, data protection business, network security business, is, you know, you start the conversation up with them about what you may need to do to try to move toward a mobile-first technology, smart devices in the hands of the providers, where they are, not necessarily going to find a desktop computer to do their work or to help accomplish care for patients. And as always, there's all kind of talk about those concerns, as well as, you know, introducing smart devices. Oh, we don't allow smart devices on our network. We don't have a BYOD policy. We're not going to have a BYOD policy. And then basically every obscure technical reason why you can't innovate around the delivery of healthcare to a patient for any reason. And once again, as almost always happens in these meetings, somebody outs themselves. And I used to have folks that outed me all the time as well in my IT shop. And, you know, they say things like this. It says, well, you know, they're using their own smart devices anyway. And, you know, you just, when that comment comes out like it regularly does, you kind of have to let that sit there for a while. So I kind of let it sit on the table and just kind of hang out in the room. And, you know, I thought about it a little bit, and I said, you know, well, I'd like to politely ask a question about this. And so they said, well, sure. And I said, well, so it seems, which of course we all know to be true, that the providers are solving the problem on their own with no institutional guardrails or safeguards or anything being provided by us, me, you, technologists, being provided nothing by us. That when we should be providing innovative and secure solutions that they show their need for in their daily clinical practice every day. And then I politely make the statement. So instead of solving the problem with everything we know we have access to, are we going to continue to believe we don't have a problem? So that has to sink in just a little bit, usually, and you expect somebody from the leadership side of the house, from whomever you're talking to weigh in. And almost invariably, it comes back with this, is that we really can't answer that question in good conscience in the negative. And so maybe you move the needle just a little, but that's what we're going to have to continue to do. So in that exact meeting, I proposed an additional alternative for those folks, because you can't just hang them out and leave them, feeling like they've outed themselves and now they're in a bad position, because you really want to help people. That's the point of what we do in healthcare. So I say, look, we've got to ask ourselves if we can continue to use privacy and security concerns as a scapegoat. I mean, I don't believe we can continue to use it and excuse ourselves for the lack of innovation and adoption of mobile technology. Well, I don't like to leave folks like that in the lurch, and I don't like to leave them like, well, we just, sort of outed ourselves, and now what are we going to do? So I always throw people a lifeline. So I proposed an alternative for the group, and it goes along these lines. I'm like, look, we have to ask ourselves as IT professionals in healthcare, can we truly continue to use privacy and security as a scapegoat? I mean, that's the reality of it. We can't. We can't use it as a scapegoat for the lack of innovation, the adoption of mobile technology, when in fact, we all know we can harden our systems, protect our systems. We can even move our communication systems to more secure cloud-based environments. The world's not going to stand still while we anguish over the next security threat. We have to find a balance between information security and effective delivery of healthcare to the right patient at the right time in the right place. Secure mobile technology in the hands of providers can ensure that we don't sacrifice the delivery of patient care at the most critical time it is needed, preventing death or disability, while also protecting the data and delivering care in the most efficient and cost-effective manner. We can do that. It's possible. So I'm going to leave you with a few examples across the United States that I know of personally. One of them I've sort of already mentioned, that I've spent some time in some state coordinating centers and some transfer centers, but to put a fine point on it, several states have already understood the dilemma of mitigating surge around COVID patients and other surge events, essentially trying to locate and coordinate available beds or other resources. And you know what? They're no longer manning big phone banks of control centers with the phones ringing off the hook. Do they have phones? Sure, they've got phones, but you know what? They converted over to mobile technology, using single channel communications over a single patient event with a networked, multi-team, multidisciplinary, effective collaboration in real time and on the fly. And guess what? It works. Everybody's on the same event. Everybody's looking at the same data. If you're looking for a bed for a COVID patient who also needs dialysis and they also are diabetic and you don't have dialysis, then you quickly, ignore that thread of communications and you let somebody else who may meet that need come to the plate. So it's happening already in the United States. We've got several examples across the country where that's the case. I will tell you that I've been in transfer centers where the phones used to ring off the hook and now they're not ringing off the hook to the same degree because they're using platforms and communication logistic platforms that are effective at moving all sorts of synchronized data such as video, voice, telephony, all those sorts of stuff, along with images, multimedia, audio clips, all of this stuff, enabling interactions of teams across organizations without picking up a phone. I asked a transfer center lady just recently, by the way, who was really excited about some of the things that we're doing, and she said, "Joey, I get it." And I said, "I'm glad you get it." I said, "I have one last question for you." And she said, "What's that?" I said, "Well, how many patient transfers can you facilitate with phone calls?" She said, "One at a time." And I didn't even have to say anything. She said, "But now I'm doing multiples at the same time, and I'm not even on the phone." So I think we have a lot of evidence that things are changing in the healthcare environment. I think that the pandemic has been awful for all of us, but it would have been even more awful for us if we hadn't learned the lessons through the pandemic, and we continue to learn them. So I've got some other examples across the country. So, EMS agencies all across the country are using single multi-channel communications and live video to consult with medical control, to accurately assess and treat patients in place, or transport patients to alternative destinations. Wow, that's a concept, huh? Provides better quality of care, good. Convenience for the patient, good. And their families, that's good. Reductions of hundreds of emergency department admissions. Think about that. Freeing up hospital availability for those patients in need of acute care. Another example is during a particularly devastating winter storm in 2021, one major health system saw its daily number of calls and hospital transports double. Think about that. Doubled. During the post-holiday surge of COVID-19 patients, their staffings were already down 15% due to people getting sick or secondarily contracting the virus. But they leveraged a modern communication, mobile-first communication platform. Paramedics began treating patients in place. They'd put them on a list for follow-up by clinical staff in medical control, or they sent them with a medic or by that some other transport means to an alternative destinations, thereby relieving the overburdened hospitals. So as you decompress any part of the healthcare system, it decompresses all of it. And finally, I'd like to take a look into the future, beyond what we've even talked about so far, but thinking about how we navigate the internet on behalf of patients and providers. Imagine that an adolescent patient or their family calls 911 during the midst of their first ever behavioral health crisis. Or you could say somebody who's fallen out of their behavioral health care plan. So dispatch is going to send an ambulance to that location with a crew of paramedics who are going to transport that patient to a local emergency department, because that patient needs to be medically screened before they can actually have any intervention on the behavioral health side of the house. And they're going to be admitted to the emergency department, both the patient and many times their families. And they're going to sit in a bed for an undetermined amount of time, although I will tell you, I don't talk to anybody in emergency departments across the United States that does not say that all behavioral health patients are taking up beds in their department and they can't effectively get them to the right place to get them the real treatment they need. So that's the norm. So that's where we are today. But imagine a different world. Imagine that same first time 911 call for an adolescent behavioral health emergency. And imagine that an innovative, forward-thinking EMS agency and their medical director and a network of behavioral health hospitals for adolescents have decided, you know what, there's a better way. And so they craft a policy or a protocol around medical screening in the field. So once again, they call 911. Once again, an ambulance is dispatched. Paramedics show up on the scene. They have access via live telepresence and televideo to their own medical control. They can do by a very strict protocol in a set amount of time, they can determine medical screening has been completed and they're medically stable. And instead of that transport going from that scene to an emergency room, they instead connect to all of the bank of behavioral health facilities who are on this same single multi-channel network, and they place the patient in the right place. Oh, imagine that. Somebody who needs behavioral health actually going to a behavioral health facility in crisis. So imagine that world. And that is really possible. So in our new world, EMS is now delivering that patient to a place for the services they really need, creating a better experience for both the patient and their family. The patient and their family win. EMS wins, providing better community health and delivery, and the entire community healthcare system wins with effective and efficient community healthcare delivery. I'd like to close by thanking Beckers for this opportunity to discuss how to leverage mobile technology to navigate the internet on behalf of providers and patients. Thank you for your attention today, and I would welcome any requests for information. Thank you.